Just an announcement before we get started. The building has just let me know that they were people did not keep their personal items outside, so if nobody's going to go to grab purses and bags. It's an open building, so we're not the only group here. We'll wait for you to get back.
So we'll do that. Just the vote.
I don't think I've just been
I did check, and it looks like it's doing okay. At least it did the first time. I don't know how it'll be in this year, but if we think I'm closer, so hopefully it should be okay. Last year we had like we were trying to get them people like, but like they didn't really wear half of them. Oh. The flower pot? Yeah, that was awkward placing for the video. Yeah, but like by the time I realized it was like
next time for the next time.
Yeah, that's good.
But it's just like I was like looking at her and like I bet all you can see are like flowers.
Yeah, that is exactly what it was. But at that point it was like, oh, I'm not gonna no, it's yeah. And it was a nice spot to have flowers up there. Like, no, it looks nice. Yeah.
But I like I guess in general, you don't put things on dead people. I never thought about that, but I see why. You know, like
right. Or even like for personalities.
Yeah. Yeah, that's true. Actually, all I can do is like flowers from my angle. I'm trying to like see your face. Yeah, I need to do something to
Hi everybody. Can you guys hear me in the back? Good. First, we wanted to thank you guys for all coming. It's been hectic, but the planning's been very good. The board, thank you guys to the health staff board for helping things run really smoothly today. I'm going to be introducing Dr. Brawley. He's currently the Chief Medical and Scientific Officer and Executive Vice President of the American Cancer Society. He is responsible for promoting the goals of cancer prevention, early detection, and quality treatment through cancer research and education. He also is currently serving as Professor of Hematology, Oncology, Medicine, and Epidemiology at Emory University. I first encountered Dr. Brawley's work as a first semester student at Georgia State in the public health program. We read it for Intro to Healthcare. And it's how we do harm. To say that it was reading this was a turning point. I came out of college fresh, young, didn't really know what I was getting into with public health, and immediately we jumped into this book. And it really shines a light on all of the issues in the healthcare system, and especially relevant into being into Atlanta and hearing stories that are from Atlanta. Dr. Brawley's writing opened my eyes to the disparities in our community, and it really encouraged me and kind of is what drove me to start getting involved in HSTAT. There's a really great quote that I liked in the book. If you don't know and haven't read it. Our medical system fails to provide care where care is needed and fails to stop expensive, often unnecessarily, and frequently harmful interventions, even in situations when science proves these interventions are wrong-headed. I think as leaders in the community and as people that are interested in this, it's our responsibility to make any kind of changes in the healthcare system. So I'm very grateful to introduce Dr. Brawley.
Thank you. It's wonderful to be here. I really appreciate you guys coming out on Saturday afternoon to do public health and science. It's really deep. I'll talk to you over the next 45 minutes a little bit about disparities in health. Some people are now wanting to call it health equity. And by the way, it was first called disparities in health because David Satchin, the Surgeon General, found that there was a lot of political opposition to programs that were intended to reduce disparities in health. And so he said, why don't we start calling it health disparities? And I want to see congressmen say, I am against programs to reduce disparities in health. As we talk about Medicaid expansion and other things, we might want to think back about that and perhaps do it again. Some people have wanted to call it health equity. I always believe that people who give talks should disclose where they get paid. I work for the American Cancer Society at Emory University. I have a gig with Turner Broadcasting. I am a medical consultant to CNN. It's my job to make Sanjay Gupta look good. And they have decided that occasionally they'll put us on TV together and the contrast makes him really look good. And I do some stuff for the National Institutes of Health and Federal Government. You've already heard about my book. I'm not here to push selling that book, but I want to talk about some of the things that actually are in the book. First, the concept of disparities, and then we're going to look at it in a number of different ways. And the whole theme of this is that there are disparities in health and we need to be attentive to them, as well as we need to tell patients the truth. And I'm going to talk a little bit about how we need to actually be careful how much money we spend on medicine as well. Now, the definition of disparities is there are differences amongst populations. Those differences can be measured in a number of different ways. It can be incidence rates, it can be mortality rates, it can be survival or quality of life. For survival, we frequently use the proportion surviving 5 years. We can use median survival for a disease. For quality of life, it's much harder to measure. I wish we had better measurements of quality of life, especially when it comes to pain, because there are tremendous disparities in terms of pain and suffering when we look at populations, especially when we look at poor populations versus wealthier populations. Now, that gets us to how we categorize populations. One can categorize by sex or gender, and I keep being reminded that they are different. One can categorize by race, which is a socio-political categorization, more about that in a bit. Ethnicity and culture. Area of geographic origin, which is very different from race, but linked to it, and very different from ethnicity and culture, but frequently linked to it. Socioeconomic status, which can be measured in a number of different ways, education or income or family income, or how we usually do it in the United States. In Europe, they actually have a deprivation index. The Scottish deprivation index actually has 120 questions, and after answering those 120 questions, people are fielded into 7 different categories. The Scottish deprivation index actually takes into account the fact that someone may live in a very wealthy neighborhood, but they may be made. Whereas in the United States, when we do a lot of things in the United States by area of residence, by census tract, and that does not take that into account. Region of residence is what I'm really talking about there. Now, I mentioned earlier that race is a socio-political construct. Unfortunately, many people, especially politicians, especially black politicians, try to turn it into a biologic construct. It is not. It is actually, in the United States, all of our racial data is defined by the Office of Management and Budget about 2 years before every census. Race is a socio-political construct. The anthropologic community and the scientific community are very clear about that. Best way that I can give you, best examples I can give you, does anybody know someone who is from India? Okay. If that person came to the United States prior to 1950 and they're still alive today, they have been 4 different races in their lifetime. Everybody knows Barack Obama, right? Everybody knows who he is? He turned black in 1980. In the 1970 census, the instructions were you should declare yourself to be the race that your mother considers herself to be. When I show you race data, keep in mind Barack Obama was white in 1970 and black in 1980. Some of these socio-political categorizations that we call race are really convenient ones. For example, Asian Pacific Islander is one of our racial categorizations. Now, I want you to think of a native Hawaiian, a native Samoan, a Korean, and a Pakistani, and tell me, what do they have in common? They're in the OMB categorization of Asian Pacific Islander. That's about that and the fact that they breathe air is about the only that they have in common. Now, some people say, well, aren't there these biologic differences amongst the races? And the answer to that is there's some biologic differences, but not that many and not that important, especially when it comes to many diseases. Now that we've gotten into the genomic revolution, some people are trying to define race by genomics, trying to define populations by genomics, and there's a little bit that can be done in that, but you need to be very careful. It's more scientific, it's more objective, but you still need to be careful. We know about sickle cell disease in the United States. There are textbooks that say it is a disease of black people, or African American people, or Africans. Well, if you end up going to medical schools in Europe, or in South America, or in Africa, they teach sickle cell disease this way. There is an area of the world, draw a circle around it, if you have a map or a globe with your finger, where people come from who have sickle cell disease. Now, an area of geographic origin includes southern Spain, southern Greece, southern Italy. It goes into Syria and Lebanon, and it swoops down into sub-Saharan Africa. That area of geographic origin does not include South Africa. I just defined for you areas of the world where white people come from and we have sickle cell disease, and areas where black people come from and we don't have sickle cell disease. But in the United States, our medical textbooks define it as a black disease. By the way, there was a malaria epidemic thousands of years ago, and people who have sickle cell trait actually have resistance to malaria. This is actually evidence of survival of the fittest and evolution. Anybody here live in Cobb County? I don't want to offend you guys. Keep in mind, Cobb County is outlawed teaching evolution. Cystic fibrosis is a disease of Northwestern Europeans. Ethanol dehydrogenase deficiency is not really a disease, but it's this phenomenon. If you know somebody who's from Japan or China, sometimes when they drink alcohol, especially when they drink hard alcohol like whiskey or vodka or sake, they turn red, they flush, because they have low levels of the enzyme that actually handles alcohol. It's called alcohol dehydrogenase. Those people get drunk very easy. It's common among people from Japan and the eastern part of the Asian continent. Okay? This is a genetic issue that you can link to people from one particular area of geographic origin. Now, I just told you this. Do not assume that the next big Japanese guy you run into cannot handle his alcohol. Do not assume that. You know, the prevalence of this enzyme is higher among Japanese people, but it's not the predominant of Japanese people, and it's not exclusively of Japanese people. There are whites, there are blacks, people from Europe and Africa who also have alcohol dehydrogenase deficiency. And what I'm trying to talk about is the concept that prevalences can be higher and lower amongst populations. G6PD deficiency, glucose 6-phosphate dehydrogenase deficiency. I stayed up all night practicing saying glucose 6-phosphate dehydrogenase. It's a deficiency that's very common among people in the Middle East going into India. Some people in Africa have a higher prevalence. But again, prevalence is an issue here. Now, why are there disparities in health? I'm going to give you the bottom line right now. In the United States, there are disparities because there are treatments available and some people do not get those treatments, or some people do not get those treatments as well. There are some folks who are always worried about, can they get the treatment? Those people also need to worry about, can they get the treatment well? Now, race is important in the United States in its socioeconomic definition because poor people, of which black people tend to be poorer than whites, Hispanic people tend to be poorer than whites, but white people too sometimes get the treatment but don't get the treatment well. Quality is an issue. And I say that because there's a lot of studies about is it available, there's not a lot of studies about is high quality available. And this is especially true when we talk about things like mammography screening and breast cancer and so forth. There are also cultural differences in acceptance of therapy. There are people who say no for cultural reasons. There are people who say no because their culture has become one of suspicion. I'm going to tell you why sometimes that suspicion can be appropriate. There are disparities in comorbid disease. I'm going to show you later 50% of Hispanic women in the United States are obese. They have higher rates of hypertension and diabetes. It's harder to treat their cancer if they have cancer, or harder to treat their heart disease even if they're obese. I actually have patients where we can't do a CT scan on them because the machine will not allow patients over 300 pounds. Access to care is a huge issue. I work at Grady Memorial Hospital. You would be amazed how many people have life-threatening conditions and they go without care because they can't get a ride to the hospital. Actually, in the last few years, Uber has been a godsend. There's also racism and socioeconomic discrimination. Yeah, I'm the chief medical officer of the American Cancer Society. Everybody always asks me. A guy asked me on the plane last night, how are we doing in cancer? And the answer is, from 1900 to 1991, the age-adjusted death rate from cancer is this line. It went from 64 per 100,000 to 215. And since 1991 to 2012, the last year of data, it has gone down to 166. That's a 23% decline in cancer death rate. So I think that's a good thing. Now, this slide is the death rate. Sorry, the numbers got merged here. From 1991 through 2010 or so for blacks, whites, Native Americans and Alaskan Natives, Hispanics, and Asian Pacific Islanders, using those OMB definitions. By the way, in 1980, Native Hawaiians were Native Americans. In 2000, Native Hawaiians were Asian Pacific Islanders. These socio-political definitions. And these things change over time, unfortunately. I want you to note that blacks are higher than whites are higher than Native Americans, who are higher than Hispanics, who are higher than Asian Pacific Islanders. I want you to note that everybody is trending downward a little bit except for Native Americans and Alaska Natives. Why the declines and how can we accelerate them? Well, in looking at why these declines occurs, this 23% decrease, number one was prevention of cancer, especially smoking cessation. Number two, improvements in treatment and making those treatments available. Number three was increased awareness. Number four was effective cancer screening. Screening gets emphasized a lot more than it actually gets. There's some people who are always hollering about screening and getting people screened, but they don't worry about getting treatments to the people. The 23% decline is overwhelmingly because of smoking cessation. Let's look at lung cancer. Lung cancer for men rose from really 1920 all the way up to peaking around 91 and has gone down. Recently, lung cancer death rates for women have started going down. Now, the reason for this difference, in 1955, 55% of American men smoked cigarettes. It's about 20% today. In 1965, it was 35% of women who smoked cigarettes. It's about 16, 17% today. The decline in men has been steeper and earlier because the decline in men for lung cancer has been steeper and earlier because the decline in smoking in men started earlier, and the difference of 55 to 20 is greater than the difference of 35 to 16. They started earlier and they've had a deeper decline. That's why men have had a greater decline in lung cancer death rates. I should point out to you that this 23% decline that many of us have been celebrating means that 1.7 million Americans did not die of cancer since 1991. But unfortunately, we were the 31st country in the world to have a greater than 20% decrease in cancer death rate. A lot of people say that we have the greatest healthcare system in the world. Unfortunately, I can show you a lot of data with things like this. Look at our age, our life expectancy. We're 49th in the world in life expectancy. We can actually be proud of the fact that Bulgaria is 50th and we beat out Bulgaria. If you look at infant mortality rate, we don't even make the 20 best countries of the world for infant mortality rate. If you look at infant mortality rate in our inner cities, by the way, we actually don't beat out a number of countries in Africa. The folks I work with tell me that this year we're going to have 1.69 million cancers diagnosed. We're going to have 596,000 people who die from cancer, and 148,000 of those cancer deaths are preventable. How do you figure out that 148,000 are preventable? If you just do one, I'm talking to an audience of public health folks, so it's easier to talk about this. You simply say, how many people would die if all of America had the cancer death rate of college-educated Americans? That simple question. The answer is 148,000 less than are going to die now. By the way, some of you already figured it out. I can tell in our faces. That's not the lowest it can possibly get because college-educated women have an even lower risk of death from cancer than college-educated Americans. Let's look at breast cancer. This is breast cancer from 1975 to 2012. This is black women in blue, white women in red. I want to point out that there was no black-white differences in breast cancer death rates in the 1970s. And then in 1981 is the first year we have a difference. And the difference has been greater. The delta is greater in 2012 than it's been at any time in our history. We learned how to screen and treat for this disease in the late 70s and early 80s. And this is what happens when 80% of the people we call white get good treatment, and 60% or so of the people who we call black get good treatment. Now, improvements in breast cancer mortality are number one, due to improvements in treatment, number two, due to awareness, and number three, due to screening. Screening always comes in there, but it's not as important as a lot of people think it is. Awareness and early presentation, that's a woman taking a shower saying, what the hell is this? And feeling empowered to go to the doctor and ask that question. That did not happen in the 1950s and 60s. Women would find something and then just continue with it until it broke through the skin. I've already told you, minimum expected care is what my lawyers want to say, I'm supposed to say. About 80% of white women get minimum expected care. Black women are 2/3 as likely as white women to get minimum expected care, and Hispanics are about 3/4 as likely as whites to get minimum expected care. This is a paper, Mary Jo Lund was one of my fellows. She published a paper showing that in the year 2000, 7.5% of black women in metropolitan Atlanta diagnosed with a highly curable breast cancer did not receive treatment for it within the first year of diagnosis. Enough access to care to be diagnosed. This isn't the mammogram was abnormal. This is the mammogram is abnormal, and they got a needle stuck in their breast, and a pathologist said the biopsy shows cancer. 2% of white women in metropolitan Atlanta fell into that category. Now, a large number of women get less than optimal care. Speaking of less than optimal care, I mentioned there's been a 40% decrease in breast cancer death rates in the United States as a whole. Excuse me. I mentioned it's not true for blacks, although there's been a 26 or 27% decline for blacks. These states have not had a 10% decrease in death rate. The United States is at 40% as a whole, even with these states not having had a 10% decrease. Now, you cannot blame the fact that there's not been a 10% decrease in South Dakota, Wyoming, Utah, and Montana on the fact that there's a large black population there. So disparities now, we're starting to talk about state-by-state disparities. And if some states fail to expand Medicaid as part of the Affordable Care Act, we're going to talk about more state-by-state disparities and not just breast cancer. Let's look at colon cancer. Colon cancer death rates age adjusted from 29 in 1970 to 15 in 2010. We've almost halved the risk of dying from colorectal cancer over the last 40 years. Now that one actually, we looked at it, and screening is a big mover there. State by state, huge declines if you live in Massachusetts and New York, not much of a decline if you live in Alabama, and no decline if you live in Mississippi. There are 12 states in the United States that have had less than a 10% decrease in colorectal cancer death rate, while the rest of the United States has been over 40%. Indeed, the national average is 40% averaging in those 12 states. I could get the national average to 50% if I could throw out the old Confederacy. that was an idea somebody had once, wasn't it? Okay. By the way, Georgia is one of those states, if you throw metropolitan Atlanta out. If you just cut metropolitan Atlanta, the 5 counties that make up Atlanta, DeKalb, Fulton, Clayton, Gwinnett, and Cobb, cut them out. Georgia is just like Alabama and Mississippi. This is a Kaplan-Meier plot. Those of you who are not familiar with Kaplan-Meier plots, this is time on the bottom. 60 months is 5 years. 0.5 is 50%, 0.7 is 70%, 0.9 is 90%. And this is 5-year survival over here. And this is from time to diagnosis to 5 years. For stage 1 in red, and red solid is insured, red dotted is uninsured. Stage 2 in blue, insured solid, uninsured dotted. If insurance didn't matter, and this slide was actually prepared, this was in, you guys ever hear of a radio commentator called Neil Boortz? This is Neil Boortz inspired science here. He actually said, when there was a discussion about the Affordable Care Act, he said, we don't need national insurance because anybody who gets sick gets treated. All right? And this is just to show insurance matters. If insurance didn't matter, the dotted line, the red dotted line would be on top of the red solid. The blue dotted line would be on top of the blue solid. But since they're not, it means, and since insured don't do as well at 5 years, it means insurance matters. And yes, here we have, if you are insured in America with stage 2 disease, your prognosis is better than if you're uninsured with stage 1 disease. You are better off having the more advanced disease with insurance than having the less advanced disease without insurance in the United States. By the way, I mentioned earlier that a substantial proportion of the United States does not get screened. If we could go from 50 to 55% getting screened to 80%, we could actually prevent, when we got to steady state, 15 to 20,000 deaths per year. This is actually low-hanging fruit. This is science that we already know works. Now, interesting thing about screening. In the United States, everybody thinks that colon cancer screening is a colonoscopy. Colonoscopy costs about $3,000 to do it. If you have a negative colonoscopy, it needs to be repeated in 10 years. The science to show that stool blood testing at $30 a year saves lives is actually stronger than the science to show that colonoscopy saves lives. So much so that in Canada and Europe, colonoscopy is not the preferred screening for colon cancer. Honest to God, the preferred screening for colon cancer in the United States is colonoscopy because somebody can get paid $3,000 to do it. We should think about that when we think about the fact that we have the most expensive healthcare system in the world and we don't have the best outcomes. Now, social determinants of health. This is work that my group did a couple of years ago. The whole reference is falling off. This is green is people who have more than a college degree or greater. Red is high school and maybe some college. Blue is never graduated from college. Just want to show you that causes of death are going down by 23% over the last 25 years or so. The decline is greater in cancer for college educated versus people with some college and maybe a high school diploma versus people who never graduated from high school. When we look at heart disease, college does better. When we look at stroke, education does better. When we look at cancers where the death rate is actually going up, college does better. Liver cancer, pancreas cancer, esophageal cancer, you're always better off having a college degree. And you're always worse off if you never got to through high school. This is a complicated slide. The moral of the story here is, if I wanted to get rid of black-white disparities in breast, in a number of cancers among people 25 to 64, if I wanted to get rid of a number of cancers, I would actually give African Americans, I'd eliminate the educational disparity versus the racial disparity. This is how many people in red would not die if I gave all blacks in the United States white death rates. This is how many would not die in red if I gave them college-educated death rate. You got that? Education is more important than is race. Now, let's look at prevention. Huge opportunities for prevention. Number one cause of cancer is tobacco. Number two cause right now is nutrition and physical activity. It's a combination of bad nutrition, too many calories, not enough exercise, and obesity. Think of it as a three-legged stool. Everybody talks about obesity because it's easy to measure, but it's too many calories, too many calories, not enough exercise, and obesity. And then some infectious diseases like human papilloma virus, hepatitis B, hepatitis C. Showed you smoking already, and smoking is going down. Problem is, smoking is going down. It could go down further. Here's men and women smoking rates. Here are the people where we need to focus our anti-smoking efforts. Almost a third of Native American adults currently smoke. Almost 30% of people living below the poverty level. Almost 60% of people who have psychiatric diagnoses of bipolar disorder or schizophrenia smoke. We need to focus on those groups of people and focus anti-smoking efforts. In keeping with my state disparities, these are the states that have almost 30% smoking rates. These, for some reason, Utah and California have low smoking rates. I guess in California, I should say, it's about 10% of adults who smoke tobacco. Yeah, you guys are waiting. This obesity, lack of physical activity, and poor diet thing over the next 10 to 20 years is going to surpass tobacco as the leading cause of cancer. We're doing so well with our declines in tobacco and so badly with our diet habits, which we're going to talk about today, that diet is going to become the leading cause of cancer in the United States. The triad is already the leading cause of diabetes, cardiovascular disease, and orthopedic injury. Looking at obesity, in 1970, I realized I'm the only person in this room who was alive in 1970. 15% of adults were obese. In 2010, it's 35%. Notice in other countries that we like to compare ourselves to, they've had increases in obesity, but not nearly to the extent of the United States. Among non-Hispanic Black women, among Mexican American women, among all Hispanic women, we have huge problems with obesity. Now, I'm going to end by telling you a little story about why I think that sometimes people don't trust people like me in medicine and why they actually might be quite wise not to do so. Prostate cancer is a major problem in the United States. It is the #1 cancer diagnosed among men. Only lung and colon cancer kill more men than prostate cancer of the cancers. Huge problem. We have a blood test called the prostate specific antigen test, which helps us to diagnose a bunch of prostate cancers. But it's not clear that it helps us to find the cancers that are going to kill earlier such that treatment actually saves lives. Now, what you want to just stop for a second. Cancer, what many people don't understand about cancer is there are some good cancers that would never kill and don't need to be diagnosed and don't need to be treated. And there are some cancers that kill people. Genomics is actually helping us to be able to start to say, ma'am, you have breast cancer, but it's a milder type of breast cancer. And so we're going to give you milder treatment versus, ma'am, you have a very aggressive breast cancer, and we're going to give you aggressive treatment. Well, in prostate cancer, we have not totally figured out yet if screening and treatment saves lives. Now, at the same time, we figured out screening and treatment makes money for those of us in medicine. So somebody benefits from prostate cancer screening. As a result, recommending for informed decision-making or telling the patient and the doctor-patient relationship, there are some unknowns here and some guesses that need to be made, and better you, sir, make the guess because you got to live with the end result, are the American Cancer Society and these other 5 organizations. And note, the European urologists and the American urologists all are in favor of telling the patient there are harms and benefits and potential benefits and letting the patient make a decision. There are these organizations here who look at the same data and they recommend against routine screening. The U.S. Preventive Service Task Force has gotten a lot of press, some of it negative because they recommended against screening. If you look at what the American Urological Association says about prostate screening on their website, they say given the uncertainty that PSA testing results in more benefit than harm, a thoughtful and broad approach is critical. Patients need to be informed of the risks and benefits of testing, the risks of over-detection and over-treatment. That is, treatment of a cancer that was never going to kill you should be included. Here we have this group of folks. This is Zero, the project to end prostate cancer. They have a bunch of these buses that were formed by Kimberly Clark, the world's largest producer of adult diapers. And these buses go all around the country. They go to malls in the wintertime. They go to state fairs in the summertime. They hook up with a local hospital or a local urology group, a local radio station and TV station that will promote. They're doing free prostate cancer screening. They refer all the abnormalities to the local doctors that they've hooked up with. Now, their literature doesn't say anything about prostate cancer screening and informed decision making. It only says things like prostate cancer is good, prostate cancer screening is good, it extends survival. Now, those of you who've done any epidemiology know about lead time bias. Every screening test, whether it saves lives or not, prolongs survival. This is marketing. This is not informed decision making. This is marketing. And there's no mention of caution, no mention of harm. Now, these guys are out there pushing prostate cancer screening, where all the experts say there's a question mark, and men need to know about those question marks. I ask the question, why do minorities distrust us? Because of things like that. And there are numerous examples of those sorts of things. The last I'm going to tell you is the PZT story. Congress in the early 90s passed the NIH Revitalization Act. The NIH Revitalization Act noted that minorities, especially blacks, weren't doing as well in terms of many of these outcomes that I just talked about. And the act actually attributes it to the fact that the NIH does research and blacks are not in those clinical trials. And so it said the NIH is going to have to make sure that blacks are in those trials. And people who get grants from the NIH who are at Georgia State or Emory or Morehouse or elsewhere they're going to have to do valid subset analyses of the outcomes looking at blacks and whites. They have now put in the law that race is a biological categorization. Well, let me tell you the results of one of those studies. One of the early studies of the 1990s was a study of AZT versus placebo. It was designed to figure out if AZT was beneficial in treating AIDS patients. The end result of that study was that AZT decreased the viral load, increased the CD4 count, and increased the life expectancy of patients. When one looked at subset analysis, it increased the life and benefited whites. It was not as beneficial to blacks. This was published. It led blacks in Atlanta and blacks in Detroit, where I grew up, blacks all over the country, to say, why should I be taking this drug? It helps white people and not black people. Some of the more cynical said, you knew they would come up with a treatment for white folks before they would come up with a treatment for black folks. Well, the folks who actually did this trial, who were forced to do the subset analysis, were really disturbed by the outcome, and they did further study. And they found out that for socioeconomic reasons, transportation, having to do other things like work and not tolerate side effects, blacks were much less likely, blacks on the study were much less likely to take their AZT. I'm going to tell you a secret. If you don't take a drug, it's not going to help you. Now, but that has been well known since 1995, that finding that AZT didn't help blacks was purely because of a compliance issue. It's been known since 1995. Here in 2016, 21 years later, in Atlanta, we are still battling the rumor in the black community that AZT is a white person's drug. It doesn't help black people. Keep in mind, it was the Congress that decided that this had to be done. It was the Congress that decided the Congress who put into this legislation that race was a biological categorization. Again, another reason why folks should be careful in trusting politicians as well as doctors. So I'm going to end by saying that the moral of the story is we need to respect science and scientific principles and educate as much as possible. We need to intensify our tobacco control efforts. We need to focus on good nutrition and physical activity. And we need to realize that adequate health care is a human right. And I'm going to stop at that point. Thank you very much. Do we have time for questions? Yes, ma'am.
So this is kind of a two-part question, but so I came from public health into medical school, and one of my frustrations in public health was how rarely socioeconomic data is available, like the things you showed for some of the cancer. We don't often have that across medicine in general. And then when I started medical school, seeing how like never being presented with socioeconomic data in terms of disparities perpetuated this idea of race as a biological construct amongst my classmates. So in the perfect world, what would you want, like as a researcher, in terms of like, what do you think we should be asking in medical records or in surveys? What would you really like? And in terms of education, what would you like?
Well, if we're going to collect race data, and part of it is we should, because there's a socio-political meaning and there's a disparity for socio-political reasons, we need to ask race data. In California, when the California statisticians who deal with this data have what they call the Filipino problem. Everybody who dies Filipino has a Hispanic name and ends up being coded in somebody's database as Hispanic and not as Asian, purely because nobody asks people what race are you. My mother-in-law is actually in the Emory database as being white. She got really upset about that when she found out. But anyway, she's black. But I do think we should collect race-based data. I think we should collect data based on insurance, and data based on Z+4, which will give us some income data. I think the most important thing is we all need to be aware that these disparities exist and be aware of the desire to try to reduce these disparities. Yes, sir?
So in some ways, I think medical schools are doing that. I remember learning about thalassemias, region specific, but certain diseases are just China or Africa, except for South Africa. How would you, with the amount of information in medical school kind of already reaching a maximum, how would you work that in for medical school students? How could that be fit in what we would learn? Because I honestly, in Africa, I know regions of Africa, but I know very little about regions of China.
Yeah. Well, to a certain extent, you're not going to need to know about those things unless you end up practicing in China. And even if I were to have some tidbit of information that would kind of help you with this, I guess the best I would do is what a Jesuit priest told me a long, long time ago, and that is question everything you know. The first information falls into three categories: what you know, what you don't know, and what you believe. Question everything routinely. Question what you know even harder. Because so frequently the things that we think we know, after a little questioning, it turns out that we really don't know to be true. I mean, there's a whole bunch of people who just knew that lung cancer screening with chest X-ray would save lives. And so much so that we implemented it in the 1960s. And in the early 90s, Ann Landers, you guys know who Ann Landers was? She was really big in the 60s and 70s. She and Dear Abby, which is her sister, ironically, were advice columnists, and everybody listened to them. And they used to, people used to buy the paper just to read the Ann Landers column. She went on this tirade about lung cancer screening and said, "You're a fool if you don't get an annual chest X-ray." Well, in the late 1970s, the Mayo Clinic prospective randomized trial of lung cancer screening with chest X-ray actually showed that chest X-ray saved lives. It decreased risk of death from lung cancer by a small amount, but it killed more people through causing them to have invasive procedures than whose lives were saved. Yes, it saved lives, but it net caused more people to get medical procedures that killed them. It net harmful. People just didn't question chest X-ray screening. Same thing happened with prostate cancer screening in the 90s until about 2010, really. We had an epidemic of prostate cancer screening. Same thing happened with breast cancer, bone marrow transplant and breast cancer. That happened throughout the 1980s and 90s until 20 years into it, studies showed it was net harmful. We all need to be a little bit more skeptical, and we all need to especially question people who are early into or early adapters of any new technology. Yes, ma'am.
I'm just interested on your perspective about cognitive, personalized medicine or precision medicine.
Yeah, well, it used to be. Go ahead.
The new initiative. Do you feel like that this person did it up? Do you feel like that's something that will help bridge the gap, or even cause more disparities considering?
Well, are you talking about the field of precision medicine, which used to be called personalized medicine, or are you talking about what Joe Biden is trying to do?
So I think the part.
Well, let me answer the first part and now go to the second. Over the last 50 years, since really Richard Nixon signed the law, the National Cancer Act, which many people said was the nation declared war on cancer. We have learned a lot about what goes on inside the cancer cell. And we have learned that when someone has lung cancer, their cancer might not be fueled at the cellular level in the same way as the next person who has what under the microscope looks like the same lung cancer. And we've learned that the treatment for this person might very well be different from the effective treatment for this person. And for the third guy, we may not even have an effective treatment yet. And we're learning how to say, you have breast cancer, and the thing to treat you with is a drug called Herceptin, because your cancer expresses a receptor that drug blocks, or tamoxifen because your cancer expresses a estrogen receptor, which that drug blocks. And so we're getting much better at it. Instead of precision medicine or personalized medicine, I actually like the word tailored medicine. We are fitting the treatment to the individual person and their cancer. And we're having some success with that. We're helping some people. In lung cancer, it has been an amazing thing. For about 15% of the people who have widely metastatic lung cancer, it hasn't helped the other 85%. Now, Biden has, and President Obama have started this project. I don't know where it's going to go, to put more money and effort into cancer research. I was a little worried when President Obama was talking about curing cancer, because many of our models nowadays are to convert cancer more into the diabetes or HIV model of people who live for a very long time in peaceful coexistence with their active disease. My goal in non-small cell lung cancer is not to cure the person with stage 4 disease. It is to keep them as active and as asymptomatic as long as I possibly can. In breast cancer, with Herceptin and tamoxifen and those things, we're doing that in some women now for 10, 12 years. This is not new stuff. Some of this precision medicine stuff started in the late 90s. I have one woman who I talk to regularly who has lung cancer, stage 4 lung cancer. She's been going quite well for almost 5 years on one of these personalized medicine things. 5 years ago, most people who were diagnosed with her type of lung cancer died within 12 months. She happened to be one of the lucky ones who got this drug, and now the drug is available to everybody. But it only helps a small number of people who have the kind, who express the types of things that her cancer has. So I'm hopeful about the Biden-Obama moonshot. I have spoke publicly for it. I've done a lot of interviews for it. I do worry that they're talking about cure. Most of my colleagues actually says, well, we'll take the money and find something good. We'll convince them later that being alive 10 years with metastatic disease is better than being dead 6 months after diagnosis, and they'll forget about the cure thing. Yes, ma'am.
What do you see as the path forward for shifting the mindset of being profit-driven to more patient outcome-driven?
Well, as I look at the older docs who went to medicine more to make money and buy nice red sports cars, the younger docs, maybe it's because it's so expensive now. When I talk to younger docs in their 30s and medical students in their 20s, I find that they're much more interested in the social questions than my generation. So among doctors, that may be changing and may have changed. Even among doctors of my age, I wrote that book, which was highly critical of medicine, and the American Society for Clinical Oncology gave me a Lifetime Achievement Award. And I had to accept it and say, well, I'm not finished yet. But some of the bad actors, in the book I say that the healthcare system is corrupt, and people who should be blamed for it are doctors, nurses, hospital administrators, drug companies, uh, uh, health insurers, lawyers. You know, there's probably somebody who works in food service at Emory University Hospital who is not to blame for the corruption in medicine. Everybody, patients, patient advocacy organizations, including my own, are all to blame for this corruption that's going on in medicine right now. And the oncologist amazed me that I got this call. I thought they were going to throw me out of the American Society for Clinical Oncology and wanted to give me an award. So I am a little bit hopeful. When I give my talk about cost of healthcare, I am discouraged that we're running out of time. If the last 25 years of healthcare costs predict what the next 25 years of healthcare costs, the cost of health insurance and out-of-pocket costs for healthcare for the average family will equal average family income in the United States. There literally, if healthcare for the last 25 years, if the costs continue at the rates that they have been for the last 25 years, for the next 25, there's no money for food. You know, no money for anything but healthcare. So there will be healthcare reform. The question is, do we actually do something? Do we actually do it, think about it, and figure it out, or are we going to let the economy collapse and then try to rise up out of the ashes? Yes, ma'am.
So you kind of touched briefly about how Medicaid has not been expanded in some states, and Georgia is one of those states. Why do you think Georgia and some of the other states have chosen not to expand Medicaid, and what do you think it's going to take for those states to expand?
I'm going to tell you something that's very true and very politically incorrect. There are a whole bunch of folks who could give a damn about poor folks who need help. I would point out Georgia's especially bad, because I would point out that Georgia has essentially done Medicaid expansion for old folks' homes. And, elder care facilities, they essentially have it in Georgia. Medicaid pays for elder care facilities. Now, why would they expand it for elder care facilities and not expand it for Grady or for other major hospitals? The big hospitals don't donate to political campaigns. Quite honestly, that's corruption in Georgia. When there's a book that was recently written about those 30 some odd miners that were trapped underground in Chile. Remember that? And the Chilean government spent $30 million over a 2-month period of time to get them out. After years of refusing to spend just a couple $100,000 a year on mine safety equipment, they decided to spend $30 million in 2 months to get 30 guys out. The difference is those 30 guys were identifiable human beings, whereas the miners that they weren't going to spend money on the safety equipment for and did not spend money on the safety equipment for the quarter century before that, they were not identifiable human beings. That's part of it. But you have to forgive me. In 2009, I got sent away on this thing called the Surge in Iraq, and I was put on a Navy ship with sailors and Marines out in the Indian Ocean. And if you have to go to war on a big ship. Air conditioning, no sand. But every time we came to port, we walked under this sign that said, "We're Americans, we leave no one behind." So we're meant to remind the Marines who were going ashore if they were going ashore in battle. And I did that for 6 months, come back to Grady Hospital. I walk into Grady every morning. I look around and I say, "We're Americans and we leave a hell of a lot of people behind." And unfortunately, it has become become very trendy to not give a damn about other Americans. It's become very, very trendy. That's why healthcare. By the way, those of you who don't know about Medicaid reform, in all 24 states that have refused to expand Medicaid reform, it would actually cost the state governments less money if they expanded Medicaid than it would cost them to not expand Medicaid. Yeah, they could get health care for a large proportion of the patients of the population in their state that the federal government would pay for if they just expanded Medicaid. You know, and yet they choose to spend the extra money. You know, we have the same issue with prisons and schools. It just amazes me how much money states are willing to spend on young black men as long as it's in prison, and not willing to spend it for them to go to school.
I think we have time for one more question.
Yes, ma'am.
Hi, Dr. Brawley. I am so honored to be in your presentation. And recently, before one week before, I had read your book, How We Do Harm. And in one of the chapters, you had mentioned that black people have, I'm sorry if I'm not sure, and you have mentioned that black people have difficulties living in doctors like us.
Mm-hmm.
And you have linked this quote with the Tuskegee study where syphilis patients were not given penicillin, and you have also linked this with other several trials where black Americans were like enrolled in the study without their consent. So what do you think? Is this trust rebuilt? Have we been able to rebuild this trust?
No, I don't. I think things like the prostate cancer example, which is still going on today. I think some of the things actually have the NIH revitalization law. I actually think that they are legitimate reasons for blacks not to trust us. So rather than getting better, I actually think it's gotten worse because there's actually data and evidence out there on why we should not, why blacks should not trust the system to help them. The Tuskegee syphilis study is an interesting thing. My next book is a lot about it because I actually got to meet both some of the men who ran it and some of the people who ran it. And one of the things that is not out there widely circulated, you can see it if you look hard enough for it. The Tuskegee syphilis study started in 1930 because some well-meaning white people were upset that all the syphilis control money was going into white communities in the southeastern United States. There was an epidemic of syphilis, and blacks were cut out because it cost money. And one of the theories that had gone on for 40, 50 years was that syphilis did not kill blacks, it killed whites. And syphilis affected the brains of whites and so forth, but not blacks. And the syphilis study actually started, it was actually what we now would call a cohort study, a case control cohort study. Those words, case control cohort study, are 1960s words. But the syphilis study was a case control cohort study, if they didn't call it that. They compared 300 men with syphilis to 200 men who did not have syphilis over time to ironically show that syphilis actually did negatively affect black people. It's kind of ironic because the folks who ran the syphilis study are thought of as ardent racists, and how could they have done it? But they were actually trying to prove that syphilis affected black people and that we shouldn't ignore the syphilis problem in the black community. It's sort of totally, by the way, those ardent racists used a lot of black medical students and nursing students and interns at Andrew Hospital to help run the Tuskegee syphilis study in the 1930s. And black nurses and doctors who did well were sponsored to go to the University of Michigan and Boston University up north to do residencies. So those racists were so racist that they helped black kids get decent medical careers. But that's a part of the syphilis study that's never talked about. You know, I'm not at all saying that the syphilis study was a good thing. It was a horrible thing. They did things to people and did not tell them they were doing them. Because of them, there were wives and kids who got syphilis and other things. It was awful. But that's another turnaround. But another reason why, if I were black, I'd have trouble trusting us in medicine. Okay? I'm around if some of you guys have questions you want to ask me. Thank you very much.
So there's going to be a break, and then we're moving back in the other room to finish up.
Clarkston, serving for the women of Clarkston. That's Ari Simone and Diabetes Improvement Team at Good Sam Health Center. So Julia Richardson. So you guys can come up and take a seat. And like as we did last time, we're kind of going to take some time to go tell us about your projects, and we'll have some time for questions. So we can start with Julianne. Just tell us where you're from and what you've been doing, and as much as you want to tell us.
All right. Hey, everybody. I'm Julian Richardson, MD MBA student from Emory University, and I'm on the Diabetes Improvement Team at Good Sam. It's more of a quality improvement initiative. So it started by Byron Crow, which is a fellow medical student at Emory. We had an idea of trying to expose medical students into quality improvement. It's been a very big push, especially with the ACA and a focus on quality of care over just generating increase in revenue. So within like the quality, I guess the calculation, you want to increase whatever you're looking at, whether it's like improving life expectancy while decreasing costs, and that's what they define as quality. So it's an interdisciplinary team. We have MD students, MBA students, FU students, doctor of physical therapy students. I think that's it right now. We don't have any nursing students currently, but I'm specifically working in the dispensary. So Good Sam it's not really a pharmacy, but a dispensary for their patients. And we serve a largely Western population, and there's a high prevalence of diabetes at Good Sam. So our question we wanted to answer was essentially how can we come in and increase the care, increase the quality of care, of diabetes care to these patients without increasing the cost. So we focused on these things called PAPs, which are it's one of those medical things where I know the abbreviation, but I can't remember what it stands for. Prescription assistance programs. So these Merck will essentially if you meet a certain threshold, you can apply to these programs and get free medications. So what we did, we went in and we essentially just went in, we talked to the people that worked in the dispensary, created a process map because we wanted to develop just a standardized way of how they're applying their patients to these programs, just so it can be more efficient. And the next step that we're currently working on is increasing provider awareness. So we developed a one-pager with the individual companies and specific drugs and certain characteristics of the patient needs to apply. And we're currently initiating that, and we're going to analyze it and just do the step-by-step process of quality improvement.
Thanks so much. And we're going to do the same thing as last time. We'll do questions at the end. So Ms. Ari Simone, can you tell us about her work?
Hi, I'm Ariadne. I'm an MD and PhD student at Emory, and I'm excited to be here today to share with you about how we've been using student innovations in the Clarkston community to help reduce health disparities and inequality. Even before innovation, I think there's first has to be an idea and also a problem and an opportunity. So in our case, the problem was related to the considerable barriers that refugees in Clarkston face in accessing affordable and also quality health care. And the opportunity for us was to bring motivated people together, students, to try to be part of the solution. So let me first begin by kind of giving some background and also setting the context for our project. So Georgia welcomes around 2,500 to 3,000 refugees every year. And there's 5 local agencies along with, with a large network of organizations that then help resettle refugees. The refugee population in Georgia is very diverse, with people or residents coming from Burma, the Congo, Afghanistan, to just name a few. And Clarkston, Georgia specifically is a 1.1 square mile city just outside of Atlanta, and it's a major refugee resettlement area. Since the 90s, around 60,000 refugees have been resettled in Clarkston. They come from 6 continents, about 50 countries, and from roughly 150 different ethnic groups. They've resettled in this community because it's really close to Atlanta, so a major city. It has easy access to public transportation, and there's an abundance of affordable housing. While culturally, ethnically, and racially diverse, Clarkston, though, is a low resource community, where almost half of the residents live below the poverty level, a third are uninsured, and many are unemployed. Although Clarkston is nearby to large medical facilities, there is a lack of primary care physicians who are willing to serve the uninsured and also underinsured people of Clarkston. So the people of Clarkston face then high out-of-pocket costs and limited linguistic and cultural competency among the private medical and dental practices that are located in Clarkston. So because of these considerable barriers that they face, they delay seeking medical care and instead utilize emergency services for urgent and even routine healthcare needs. So out of this problem or this context came the first big idea for innovation in 2013, which was to open a clinic in the heart of Clarkston in response to these unmet health needs. The clinic was called, or is called, the Clarkston Community Health Center, and it was founded in 2013 by a group of local clinicians, and it opened its doors in early 2015 as a patient-centered medical home with a mission to provide quality, affordable, accessible, comprehensive, and culturally linguistically sensitive care within the Clarkston community. The CCHC is funded through grants and private donations, so it's able to provide free health care to uninsured patients. They offer adult primary care services every Sunday from 10 a.m. to 2 p.m., and then mental health and pediatric services monthly. The second idea for innovation came several months ago. So 2 other MD/MPH students, Mia and Jesse, are medical student coordinators of the CCHC, and they realized the need to conduct a women's health community assessment in Clarkston, because currently the CCHC can't and doesn't offer women's health services. They recruited Aya, Iris, and me, 3 other MD/MPH students, to help launch the first phase of their community health assessment during the month of our social medicine elective in February. So typically a community assessment involves both determining the needs of a community and the assets or the resources in the community. So the first phase of the project was to determine the existing women's health services available in Clarkston or in DeKalb County. And the second phase involves surveying women at the CCHC in order to determine their unmet health needs. So taken together with this information, the CCHC will determine if and which women's health services to offer. So to tackle the first phase of the project, which was that determination of the assets that exist in DeKalb County for refugee women, we first conducted a web search to identify refugee resettlement organizations who work within Clarkston. And one of the results from this search was a refugee resource guide that had been published in 2015 by New American Pathways, one of the 5 local organizations or agencies in Georgia that resettles refugees. We used the health services listed in this guide as a start and contacted the clinic staff members to determine if any women's health services were offered at the facilities. We then created a resource list in Excel of women's health clinic services for the women of Clarkston, and included also indicators that we thought would be helpful or that patients would care about, such as the distance of the location by car and by public transportation, if male and female providers were available, if interpreters were available, and if this particular clinic had previous experience working with refugees. So we were happy to find 15 sites that offer comprehensive women's health services and also have experience taking care of refugee women. So with this kind of this comprehensive guide, we included it in the resource guide that New American Pathways published, And we've printed and distributed multiple copies of the guide, included them throughout the clinic for providers, staff, and patients to reference. Additionally, we created kind of a patient-friendly version of the guide in the form of a pamphlet, and we translated into several of the most common languages spoken at the CCHC. Now, about the same time that I was beginning my work on the women's health community assessment, I came up with a third idea for innovation. It's through my involvement with the president of the Institute for Healthcare Improvement, or IHI Open School, which is a group that brings together different health professions, programs together through a shared interest in quality improvement and improving care for patients. And that's a group that also the diabetes improvement team is a part of. So our group had started a successful program at Good Sam a few years ago, and we had great results, and we were looking for another clinic to partner with. So given my work with the CCHC and a lot of promise that I saw in partnering with them, it seemed like the perfect fit. The CCHC was a relatively new clinic, so it hadn't really had the time yet to perfect all its office processes. So during a meeting with the clinic coordinators, they had identified some potential areas for improvement, so including improving patient flow and increasing efficiency, which would also have the benefit of improving just the patient experience at the clinic and improving the quality of care that was being provided. So by partnering with us, we are kind of allowing the clinic and its physicians to focus on providing kind of high quality, evidence-based medical care, where we could come in and serve as consultants from a more business perspective, make observations and measurements, and then provide recommendations to the clinic about how they can improve patient flow and increase efficiency. So to accomplish this, similar to our Good Sam project, we formed an interprofessional team of 12 with students from medicine, nursing, public health, allied health, and business. The CCHC Quality Improvement team has already gone and spent a few Sundays observing the clinic flow, conducting interviews with key stakeholders such as patients, staff, and administrators. And they've also started collecting data on how much time the various steps take as a patient moves through the clinic. So the plan is that this will be a long-lasting partnership, similar to our partnership with Good Sam, between IHI Open School and the CCHC, which will allow us to work together to decrease disparities in Clarkston. So taken together, we have really begun to make strides towards reducing health disparities and inequalities in the Clarkston community through both this women's health community assessment and the establishment of a quality improvement team. So thank you for listening, and I look forward to taking your questions.
Thanks so much, Ariadne. We have the team from Mercer. You guys want to introduce yourselves and tell us more about your project?
My name's Kirby. I'm a third year, and these are my classmates. This is Spencer and this is Matt. And we are My Team Triumph Wings of Columbus, Georgia. Nationally, it's recognized as a 501c3, so it's nonprofit. And we have decided that Columbus, Georgia needed a chapter. So we brought a chapter to Columbus that started in November of 2015. So we're still pretty new. So the basis of My Team Triumph is this kind of mentoring program for people with diverse disabilities. And it kind of revolves around captains, what we call captains and angels. So we'll start with the terminology. Captains are individuals with disabilities. Normally they're individuals with cerebral palsy or some sort of traumatic accident resulting in some sort of physical limitation. And they are kind of the leader of the team. So what happens is we pair a captain with a couple of angels, hence the name Wings of Columbus, Georgia. And these angels are able-bodied athletes, normally runners or triathlon, or some sort of kind of endurance athlete. And we pair the captain who's physically limited with the angels who are physically able. We put them in a street smart, specifically engineered wheelchair, and they compete in 5Ks, half marathons, Ironmans, whatever you would like. So we have the capacity to do all those things. We have boats, things that you can pack behind a bicycle and compete that way. And so the inspiration, at least for us, came from Dick and Rick Hoyt. If any of y'all are familiar with that kind of story, that family team dynamic. So Rick has cerebral palsy, and Dick, his father, helps him compete in endurance athletes, in athletic events all over. They do the Boston Marathon every year, they do Ironmans. And he told his father the first time that they raced that when I'm racing, I don't feel like I have a disability anymore. So that's kind of what we took as the inspiration for our project.
So I wanted to speak on how we came in contact with My Team Triumph. We had the idea, and we kind of said, we met together and said, well, how do we need to do it? You know, what do we need and where are we going to get it? And so we realized the more we looked into it, we were finding out how difficult it really was, particularly financially. I was having a phone conversation with a representative of Adaptive Star who builds these racing wheelchairs, and kind of explaining to her our story, you know, why we wanted to do it and this and that, et cetera. And we got to talking about prices, and a wheelchair, just one chair, is over $3,000, which is a lot of money when you need more than one chair if you want to have more than one kid in the race. So, you know, she knew, you know, that wasn't going to be easy for us. And so she recommended, she said, Spencer, you need to call Ron Robb, who is with My Team Triumph. He's a CEO of My Team Triumph. And so after speaking with him, he was more than happy to help. He said, we'd love to have you on board. He said, we want to do what we need to do to get that chapter established in Columbus for you guys. And in doing so, you know, we were able to get the nonprofit status. We were able to make strides in getting to that first race as little as from September to having our first race in December, where we did have 4 captains and I think almost 20 angels. So to go from a simple idea in my apartment with absolutely nothing, knowing not how we're going to do it, to try to get it from paper to action, and then to get to that first race and hear them blow the horn at the start and then see it across the finish line. What an amazing feeling to know that we could do it and we did it, and we want to continue moving forward with more races and expanding our presence in Columbus.
So I just want to speak to you all for a few minutes about where we started out and where we are now and what our plans are moving into the future. So yes, we started back, I'd say about 5 months ago, just with an idea and a department, and with the strides we've made. We had our first race in December. We had 4 captains and 20 angels, and everybody just had a ball. It was an empowering thing for the kids because they've never had that opportunity to go out in the community and pretty much everybody at the finish line celebrating with them. And for the angels, it's a sense of accomplishment and commitment that they can give something back to people that are disadvantaged. And so we did that race, and the second kind of event that we were associated with was My Team Triumph with Southern Alabama, which is their chapter, and they have an astonishing collection of captains and angels and resources in the community, and it kind of gives a sense of direction as to where we want to go, what we want to look like. We have another race coming up in 1 week in Columbus, and we are scheduled to have 5 captains and about 25 to 30 angels, and the name of the race is a Superhero 5K. And all of the kids have picked, all of the captains have picked their favorite superhero. They're going to wear a special t-shirt, and their angels are going to wear that same t-shirt on race day. So it's just going to be a really fun event, really empowering for everybody involved. And moving forward from that, where we want to go, everything we've done in the program up to this point is to make the program stable in the community, make it able to carry on hopefully for many, many years. And so what we are looking to do is expand. We've done 3 races so far, maybe do 5 races next year, do 10 races the year after that, get bigger, get more captains involved, get more angels involved, and continue along with that going to try and be self-sustaining and empowering to everybody that we come across.
Okay, thanks so much for sharing with us. Okay, never figure that out. So everyone should think of questions. I'm going to start us off with one. So something that we struggle with at times with HSTAT, I think is probably relevant to all of your projects, is we're students. We have other full-time obligations, and how do we make sure that when we're doing this work, especially in interdisciplinary teams, that we're doing it in a way that we all can have enough time for it, that it's going to continue into the future. Like, how do we make sure that this is appropriate in the community and lives on beyond the time that we move on from our elective, or when we move on to clinical rotations, or when we leave? So if anyone who feels it's relevant could speak to what have been the roadblocks and the success stories that you've faced, or what have you like thought of doing in order to make sure that your programs are sustainable?
I don't mind starting. So it's probably like cliche, but communication is probably one of the biggest things that we do. And especially communicating about where you are within your program, what lies in the future of your program, and especially trying to coordinate your individual schedules and your long-term schedules. And like currently, what we're having now is discussions of where's our endpoint and what are we going to do next in order to hand it off to the next team, or even if we can't hand it off to the next team, since we are working with individuals within Good Sam, like where can we leave those individuals in the best position to further our initiatives?
Yeah, I think along those same lines, because we're kind of underneath the same umbrella organization of IHI Open School, is how our organization kind of approaches this is that recruitment and also just the application process for each new team is so important, and that as a group and as a leadership team, you really need to be deliberate about when you start recruiting, when you see on the horizon that a leadership transition is going to be happening kind of around this time of year, right? When people are moving on to graduation and moving on to summer positions and so on. So we start our application recruitment process about a month ago, actually, and really making it deliberate. So our leadership teams or our quality improvement teams will have about a month and a half of overlap between the outgoing team and the incoming team. And then we make sure that everyone meets in small groups, make sure that the kind of outgoing, let's say, vice president of projects has time to sit down with the incoming person filling that position, and also the whole projects team as a whole, just to make sure that there's that momentum that we've got going, developing this whole new team at the CCHC. Nothing will be lost in translation as the new team comes on. I think too, sustainability with the actual organization is so key because every year there's going to be a new QI team, potentially a new group of students coming in, and that can be sometimes pretty difficult for the organization. So I think how we've facilitated that is just have it be a partnership, and all the decisions that we make as a team coming in is always made with kind of the stakeholders, both patients, clinicians, and staff administrators at the clinic. So we're not, outsiders coming in, but more like we're a whole team working together. So they're invested in us, and we're invested in them, and they also want the transition to be smooth when we bring on a new team.
What we've tried to do in Columbus is involve some of the stakeholders in our community, because Columbus right now is only a 2-year campus, so we have half the time to kind of get things accomplished and get feet on the ground. So we've included the dean of our Columbus campus. We've included some of the prominent people in the community, like we've included one of the pastors at the biggest Baptist church in Columbus, who's been there for a couple hundred years. But we're trying to get people involved who are enthusiastic about our idea and who are involved with our campus, so that there is some sort of sustainability, and there are always people there who are working with it, in addition to help, getting new students to come in and kind of creating. We're in the procedures of kind of creating a policies and procedures guide, or some sort of framework to say these are the things that we do and this is how we operate and this, that, and the third, so that we have something to pass down to our incoming students. And if you guys want to operate on that more.
Yeah, I think right from the start, the three of us said that, we're not sure where this is going to go, but we did not want it to be like, hey, let's do a race or two and check the box on our resume and say, okay, we did it, it's great. Because we want to, like she said, we want to keep it going so that the students behind us can also participate in it. And also, as Matthew said, grow within the community and reach as many people as possible. So, like she said, we get as many people involved as possible that are willing to take part in this, such as the pastor, such as part of the school. Particularly from a finance perspective, because we've got a lot of people that will be coming in and out. You come here for year 3, year 4, then you go on to residency. We wanted some transparency with the finances, particularly. So that's one thing we wanted to make sure we had established. So that, it can maintain, and like Matthew said again, to be self-sufficient, to where it can continue even with multiple students come around until it becomes a 4-year campus to where you can, have that long-term investment of time rather than being, a little short on time just with the year for year.
It sounds like some commonalities are the importance of directly engaging the community members you're working with and having it not just be a student project, and also being intentional about communication, about transition. Do people have questions for specific panel members, general questions?
I have a question for I was interested, how do you go about reaching out to the captains? Like, how do you find the captains? Do you find them at the church, or you go to like a local center where they are being treated? How do you?
Usually, surprisingly enough, finding the captains to help the disabled individuals is one of the hardest parts, because they're not out there, they're not eager to jump on board of these. It's actually hard to come in contact. We rotate during our pediatric rotation at the adult daycare and pediatric daycare center for individuals with disabilities, and it's termed the Easter Seals. And we got to talking with the CEO of Easter Seals and some of the administrators there, saying, this is kind of an idea, like, what can we make happen? And so, in talking with them, they kind of pointed us in the direction of these families. They let us come speak one night and address, about 50 different families, and we got some people that were interested. And so they contacted us and said, hey, we're interested in being captains. Let's make something happen. And then other ways that we've done it, we work all in the hospitals, and we kind of say, okay, this is what we do. This is my team trial. Do you know of anybody that this can help? And that's essentially word of mouth, how we get information out to the captains and how they get back to us.
It's kind of a tight-knit community. The families of individuals with limitations often know each other really well because they're all involved in sort of the same activities. And so, like you said, word of mouth is just purely based on families talking between each other during a certain activity. Like with Easter Seals, we've been in contact with the Chamber of Commerce in Columbus as well as the Costa Group in Columbus, and they've been great kind of helping us get our feet on the ground and get established. And Fort Benning is next door to Columbus, which has been a resource to us. And there's a program out there, the Exceptional Families Program, and they've been in touch with us about some of the military families who may be beneficial to this. And we talk about kids, but this is really open to anybody. We've talked about veterans and adults. So we say kids just because we feel like that was an easy population to start with, but it's open to everybody, and we're not, discriminating to one specific age group or disability.
Other questions for the panel? I was going to pose the same question we asked before, which is, like, when you do this work, what is important for you, for students, to know before they start? And I imagine there's, like, IHI has a lot of resources there, the open school, but, how can students who want to do this work, what should they know before they jump in, and what can they before learn, kind of?
Yeah, so I think for our organization, we have kind of two branches. One is education and one is projects. And so we'd hope for a student who wants to potentially engage with us through a QI project or one of our QI teams at Good Sam or now the CCHC, they would first engage with our organization through our projects arm. So they would attend some of our lunchtime talks, or we offer a half-day training session in quality improvement in the fall, or we offer a kind of more advanced skills lab in the spring. And then there's about 16 free online courses in quality improvement and patient safety and teamwork and leadership through the IHI Open School website. So we would hope first for a student to learn some of the basics of quality improvement before kind of taking the next step and applying that knowledge in a clinical setting, whether it's through some of our Emory faculty quality improvement projects, and we've had a few of those over the course of a year, or whether it's more long-term project or team through Good Sam or CCHC.
I feel like maybe we took sort of not a backwards approach, but you talk about kind of needing to find out the needs of your community. And to the extent we had done that just in a little bit of time we've been in Columbus, because we only lived in Columbus for 4 or 5 months before we kind of came up with this idea and started talking to folks. But we noticed that Columbus was a really active town. There are lots of running groups, there's a whole downtown Riverside pavement kind of type things where people run this 15, 16-mile stretch. But we just noticed that there was that lacking of that piece that we wanted to integrate. So we kind of just dove in and didn't really do much of a needs assessment or as much research as maybe we should have initially. I shouldn't tell you all that. But for us, it was really more of a passion than anything else. We didn't necessarily have any training or any sort of numbers in front of us. We just said, we have this idea, we really want to do it, we were passionate about it, so we just kind of jumped in and did it. And like I said, that's maybe a backwards approach, but that was our approach at that time.
And I think equally moving forward, like when we get ready to pass it down, like when we finish and we go into residency, we'd like to know that there's somebody that come in behind us, a third year student, whoever that would like to take our place. And equally, we're looking for somebody with that same passion. Whether or not they've had any experience working with anything like this, but really just to give them on-the-job training, you know, to where they can learn through seeing how we do it before we finish and you know, really just move on from that regard. But as long as they have that same shared passion to want to help those in need and they want to serve, that's really what we're looking for. And that's really enough to really make this possible and keep it going.
And I think something else that's important as far as passing programs down is the simplicity of running programs. And what we found is in establishing the program, it takes a lot of effort to get something to a sustainable level. And if you want it to stay sustainable, it's got to be easy enough to do. And so that's something we're focused on. We've made more and more things electronic and more streamlined so that we can target our captains and target our angels and communicate more effectively. And that's one thing. And then as far as the leadership of the program is concerned, one of the most important things I think is being able to pass the program down and have like a mentorship program with the people that are going to be taking over the program. This is, I feel like a program that could, if people aren't interested, it could go by the wayside. So we have to foster that interest in the program, and I think a mentorship program with people coming below us is what will really foster this program.
Yeah, so I have a question. So something that we try and do in HTAT a lot is to bring people from different disciplines to work together. So maybe if any of you have had experience with this, how do you reach out to people who are not in your discipline? And if you are able to reach out to them, how do you then make sure that you're using them in a way that maximizes their skill set, especially when it may be different from yours and maybe not be something that you're as familiar with?
Yeah, I think the kind of interprofessional nature is really key to the work that we do in the community, both in the implementation, or I guess both the planning and implementation phase of a quality improvement project. You really want that diversity of opinions and experience. So I think that decision then we're deliberate in our leadership team being from all sorts of schools. And we actually have positions on our leadership team that are called school representatives. And so we have students from medicine, public health, nursing, allied health, business, the college, and then we also have law students. And that's just on our leadership team. And our whole membership of over 500, they come from all across the university. So we kind of use those school rep positions on our leadership team to serve as our liaisons. They're kind of the eyes and ears of their cohort of students, and they report to us about, you know, what educational events or projects does the Rollins student want, or the business student, and how can we cater our curriculum and also our projects offerings to really both serve their kind of educational and also professional desires, but also then utilize those students similarly for our project, especially where we want a business student on board for a quality improvement project, just like we want a nursing perspective, medicine. So I think that's essentially, we are very deliberate about that decision, both in our recruitment and in the development of projects and our educational efforts.
Yeah, so first I just want to say, like, interdisciplinary work is inherently hard because you have people from just usually different fields of thought, and you're trained differently. The way you're going to approach problems can be very different. So, like, initially you have to be welcoming, and also you need to discuss essentially like what you're interested in, how you think, and what you're able to do. Because there's a lot of times when I bring out like an interdisciplinary day, and you go to these things, and as an MD student, like you essentially just feel like you're getting bashed by everybody. And it can be, that's kind of like the stigma that's just like there. And it's one of the things that you have to address when you are working in a disciplinary team, and you have to address it head on, because there's going to be certain perceptions that are just there. And like once you get over that hump, and you're actually familiar with the group, you actually understand like the capabilities that each individual has and what they can bring to the team, then you apply that to the project that you're doing. And you essentially just, it's a lot of like team building, which is, you can take a ton of classes on that, you can read a bunch of books, and if you don't have a good team, like even though everyone can be very competent, you're not going to be able to accomplish what you want to accomplish.
Any other questions? Thanks so much for joining us. We'll have some time later if you want to come up and talk. Thank you. Are we doing the? Okay, so to the next group, so Ms. Malika, tell me how to say it correctly.
Minyafu.
Minyafu?
Yep.
Okay, who's going to tell us about safety net pharmacies? And
so, hi everyone, I'm Malika. I'm an MD student at Emory. And so all of us have put in a prescription at least one point in time, whether it's for us or for our family. We all know we put in the prescription and then we come pick it up later. It's kind of a hassle. We all understand that it's a little bit of a hassle. But now imagine if you had multiple prescriptions, anywhere from 5 to 8. That's a lot harder. Now imagine not only do you have multiple prescriptions, but you don't really understand why you're taking those drugs, or you don't really know how to take those drugs. So it's not really surprising that health literacy is a major influencing factor for medication adherence. To simplify this process, we've created these electronic medical records, EMRs, such as Epic. There's quite a lot out there. But for those to actually really work, there has to be communications between the clinic and hospital and the pharmacies. So my doctor, a primary care doctor at Grady, she recently noticed that a lot of her patients were coming with issues related to their medications. For example, they wouldn't get their refills even though she put in her order already, or they were still getting a medication that was actually already discontinued. So with that thought process, we decided to go and see what exactly happens from a physician putting in an e-script into an EMR, a pharmacist filling out the prescription, and a patient successfully getting that prescription. So I went and interviewed 5 of Dr. George's primary care patients, and I asked them, where do they get their prescriptions? How do they fill it in? And like, what problems have they found in that process? And in addition to that, I worked with the executive director at Grady Pharmacies and a couple of retail pharmacists. And I got to go behind the curtain, so to speak, to see how exactly the pharmacy runs. And a pharmacy is a lot like a robotic assembly line. Each person has a specific task, and that's all they do. And then, but not only can they do that task, they can do all the tasks in that assembly line. So if there's a backlog, or someone's on hold with an insurance company, or just one patient has 10 medications, that's creating a lot of problems. Anybody can come in and fill in and just keep the process running smoothly. So in that way, pharmacies are a lot like troubleshooters. They troubleshoot a lot for physicians, and they troubleshoot a lot for patients. And from the physician point of view and a patient point of view, we don't really realize that happens. So where is the disconnect between physicians and pharmacists? It actually seems to be an electronic issue. We just have so many different interfaces. So I know Grady uses Epic, but the pharmacist interface is RX30, which is a completely different interface. So information is lost in the input and then in the output. And so the intricacies of prescriptions, like notes that doctors put, dosages, or the changes at the time of medication, those are lost. And in that way, patients get confused and get frustrated when they have to go back multiple times to pick up prescriptions when they're not getting the prescriptions that they need. So going forward, it'd be important to maybe have an interdisciplinary approach to creating communication between pharmacies and physicians. Or possibly a legislative approach, because we have so many different electronic ways to deal with this. There's various each hospital has their own electronic medical record system, and every time we go there, we have to relearn that process. So just maybe creating one system, a legislative approach, or interdisciplinary approach. There's lots of different ways to go about it. But the point is to enable medication adherence for patients. It's really important for there to be communications between the physicians and the pharmacists too. Thank you.
We have our next speaker is eliminating language barriers, one word at a time. This group of 3 minutes. I didn't know who was here, so sorry.
Hi, my name is Samantha.
My name is Jessica.
And we're representing Emory DMIS. DMIS stands for Emory Volunteer Interpreting Medical Interpreting Services. And this is an organization that was founded in 2011 by a group of medical students and by a group of medical and undergrad students from Emory. And they saw that there was a huge disparity in healthcare among Spanish-speaking patients. As you can tell, in Atlanta, there's a big community of Spanish-speaking patients, and sometimes when they go to the doctor, they have a hard time communicating with the doctor, and that affects their just the level of just how good their healthcare is. So as the students, they saw this and they wanted to make a change. So they created this organization, and so it's based on training students to become certified interpreters, and they go on, they get trained, they take a course through a company called Butcher Connect, and then after that they complete this training part, which is they shadow interpreters that already been doing it for a while, and they get more experience, and after they've had enough time to get comfortable with it, they go on and interpret. And we partner with different institutions.
Of course, yeah. As you mentioned, we train and certify different undergrads in the college as well as some graduate students, and we have different partnerships. One of them is with Great Samaritan Clinic, and that's the primary clinic where we do our volunteer work and assist patients, as well as work with medical students and things like that. That's a really good opportunity for every student to be able to practice and do things like that, so that's really cool. We also participate in Dr. George's OSCEs, which are primarily for medical students, and we also receive a lot of just like practice in terms of positions where you should stand and things like that. It's very important, but we don't really, I guess, look at it as very important, but being able to put yourself in a different perspective or different position, patient or position, things like that, it's really important. And it's something that I hadn't, I guess, considered as much when I was first doing my practice and my training. So that's really cool. And we also have a partnership with Grady Hospital. Even though our partnership right now is on hold because we are reformulating our contract and things like that. So that's what we're doing.
Our training is with a company called Culture Connect, and the new class, every year we have a new class, and they go through a 6-week training on Saturdays. It's like a long whole 8-hour day, and they learn about the human body, just like different ways of saying it, and interpretation in Spanish. And yeah, after that they take an exam, and then the volunteering part starts.
Yeah, we also have another partnership with that's called the Farmer Group Migrant Project, and in that certified interpreters go. I believe it's to different areas in Georgia, specifically. I'm not sure which, but they go and they interpret for these farm workers, and it's an experience that I have not personally had, but I know that some of my peers have had, and so that is very insightful as well as possibly these people have a different, I guess, lifestyle, and they haven't been to, I guess, like the doctors in a while or even at all in their life. So I think that's very eye-opening, and really I'll be able to have that opportunity in the future.
Thank you so much. During the break, you can find the 3-minute speakers and ask them questions. Our last 3-minute thesis is Shay Cohen is going to talk about HSAS.
Good afternoon, everyone. My name is Shay Cohen. I am a third-year PhD student at Morehouse School of Medicine. And today I'm talking to you about hypertension and health disparities in Minnesota. We all know that hypertension is a major problem, especially in the U.S. It's part of the 3 most common conditions that make up a larger problem known as cardiovascular disease, which is the number 1 killer of Americans. About 70 million people have been diagnosed with hypertension currently, according to the CDC, and only 35 million of those persons have the disease under control. So that means the other 35 million do not have it under control, and it costs the U.S. about $46 million annually to treat these persons when it comes in regards to health services, medication, and time missed from work. So there's a number of reasons why someone may develop hypertension, but some of the risk factors include age, gender, and race. Unfortunately, African Americans have the highest incidence and mortality from the disorder. To address this, the Cut Hypertension program was birthed in 2010 by a group of students at the University of Pennsylvania, their medical school, and the students partnered with local barbershops in Philadelphia to provide blood pressure screening as well as education and counseling to the patrons and barbers. Now, this was very important because we know barbershops traditionally are places that men go to discuss different topics. So the students thought it would be a good idea to bring this health initiative to the barbershop. This way you raising awareness, you making people think, oh, maybe I can do little things to control hypertension. Maybe they also refer them to local clinics because we know a lot of men who visit barbershops do not have a regular primary care physician, nor do they have health care. So they refer them to like local clinics that have like a sliding scale. And it was very successful. And we actually after that, it started being more studies done on barbershop prevention. And actually a doctor in LA named Dr. Ronald Victor, he received about $8.5 million from the NIH to test if this barbershop initiative, early barbershop initiative, was effective in treating or seeing results in African American men when it came to hypertension. The program was implemented by HealthStat in 2014, and currently we operate in 4 shops, 3 here and 1 in Macon, Georgia. We visit the shops bi-weekly, and we see about 25 to 35 patrons and barbers, and we screen their blood pressure and we educate them. We also refer them to different local clinics. And it's been very successful because a lot of the patrons and barbers, they're more comfortable discussing different things that might control their blood pressure. For instance, I visited a shop actually Thursday, and one of the barbers was telling me, oh, I feel kind of stressed, or I've been feeling this kind of way, can you take my blood pressure? So it feels good that they starting to notice things about what's going on, their complications, which may be a result of hypertension, and they'll start asking the questions. They're taking more initiative in their own health care, which is very important when you want to treat people. They have to care about their own treatment. You can care about all you want, but they have to be the ones. So we're hoping to expand into other shops coming up. I'm the current chair, but the new chair, I'm sure, will be expanding it. We also want to go into hair salons. However, we're trying to get enough volunteers. So we're taking volunteers. If anyone's interested, please see me afterwards. I can give you my email address, and if you want to find out more information, I can discuss that with you. Thank you.
I completely lied before. I skipped someone. So we have 1 other 3 minutes to get the presentation with Mr. Sebastian Hyman. So easy a 5th grader can learn it. My apologies for that.
So in 2014, I began medical school. In the first year, 2 years of medical school, as you guys know, you see almost no patients. You enter as a disillusioned, bright-eyed student who's used to being the best, only to discover how little you know and how average you are. Now, depression is rampant among these 2 years. Now, everyone combats this their own way. I began drawing fun, creative images, often very odd images, to help me remember hard topics and exciting things. Now, several of you have probably seen companies that do this today, and I soon discovered some of these companies myself. They produce what we call image-based mnemonic devices, or IVMDs. Now, these companies are backed by research showing that their product not only improves memory and retention, but more importantly to this discussion, it improves enjoyment and excitement of learning. Now, this interested me on a larger scale because in undergrad, I spent time teaching in underprivileged, underperforming 4th grade classrooms, teaching science. Now, the early education is extremely important to the rest of your life and the outcomes of your life. This is extremely important in the 4th and 5th grade, where STEM interests can decline rapidly. That's science, technology, engineering, and mathematics. Now, conventional knowledge will tell you that this is students do well or don't do well, but in truth, that's only about half the battle. The other half is simply maintaining student interest in STEM programs. Additionally, the drop-off in interest in STEM programs is most pronounced in female and minority students. With the help of a free IVMD image sharing company called Dr. Images MD, the Board County Board of Education, and several of my classmates, we created a small study to help us test the application of IVMDs in the 5th grade classroom. We didn't take 5th grade scientific information. We took full-on medical school information and taught it to a 5th grade classroom. Now, previous studies done by these companies have tested standard paper learning against this interactive, colorful, moving audiovisual experience. We didn't want to do that. We wanted to narrow this down to one single factor. Does the use of an image, exciting image, create more learning and enjoyment in these students? Now, we quantified our results by testing students with multiple choice questions, higher order thinking questions, and free response questions at time points before, right after, 1 and 3 weeks later. We saw drastic improvements in higher order thinking and free response questions, and we saw improvements in every category. Additionally, using a 5-point Likert scale as positive and negative questions, we tested students on their enjoyment and excitement with the lesson. And what we found was the students who took the IMBD-based lessons reacted much more positively and had much more enjoyment in the process. To sum this up, not only did the use of image-based mnemonic devices make medical school level information so easy a 5th grader can learn it, it made the information so easy a 5th grader wants to learn it. So thank you for the opportunity to come out here today and share results. And I hope that some of you will take this idea or a similar idea of your own back to your own communities and apply it in some way.
Thanks for those great presentations. We're actually going to go into the poster presentation session. We wanted to do something a little bit different. So what we wanted to do is to have everyone who's presenting a poster just stand next to their poster, and before we have everybody walking around, just say your name and give a very quick, like 1-line kind of summary of what your poster is talking about, just so people kind of know where to walk and what they're going to see. So if you can do that before we start, that would be great. Okay. You can start over here and just kind of move in this way.
And my research is titled Yet Cognitive Routines in Those in Series of Reactions.
Hi, I'm Ariadne again. These two posters are about our work at the Symposium in women's health and
I'm Jasmine Jackson, this is and we did our poster on prenatal needs, depending on what kind of needs need in the healthy land.
Hey, I'm Emma Goodstein, this is Gordon Robbins, and we did our poster on, we surveyed an area, the walkability of an area around a low-income housing community market.
I'm David, this is Morgan, this is Michelle. Along with Sebastian, we studied the STEM interests in 5th grade classroom.
I'm Sarah, this is Katie, this is Sebastian, and our project is Snack Talk, and we made healthy eating fun in an elementary school and taught them how to make the healthy snacks themselves.
And that last poster presents on here, but it's talking about an initiative where they went into a grocery store and actually labeled the different items based on the nutritional facts that they had. So before we start the poster presentation, we're going to have some desserts out here. There's also extra food if you want to grab that as well. So hopefully we can kind of walk around and see the posters and network with each other. But this has been a great event. Thanks everybody for coming. Good to see you all here.
I just want to say thank you to Sydney and Eric for organizing this for us. They were